archived for future if anybody wants to view it again. We'll go into item number 8, and that's a report of action taken in closed session. If our legal counsel will do that for us.
Yes, thank you, Chair Wong. The board considered 8 items in closed session this evening, and I would refer the public to our agenda. It's item 5. Items 5.1 through item 5.6, there was no reportable action. Item 5.7, approval of closed session minutes from January 27th, those were approved on a 5-0 vote. And item 5.8, medical staff credentialing, those recommended credentialing decisions were also approved on a 5-0 vote. And that completes our report.
Thank you so much. Are there any deletions or corrections to the posted agenda? Okay, seeing no hands being raised, then we'll move on to item number 10. And this is input from the audience. And just to give you some guidelines on that, if you have any input on items not on the agenda, you can submit those in writing to our board of the clerk, and all of that information is located on your agenda. Also, if you are in Zoom, if you'll use the icon and raise your hand, we'll recognize you. If you're going to speak, please give us your name, your full name for the record. So with that, I'll open it to audience input for anything not on the agenda. I see no hands raised. Sarah, did you receive any input from the audience via email?
No, I did not.
With no comments, we'll go ahead and close item 10. We'll go to 11, and that's the input from the Employees Association. And they're under the same guidelines as regards to any kind of audience or employee input. I see no hands. And Sarah, have you received any information from the Employees Association?
No, I did not.
Then we'll close that item and move on to 12. And this is Dr. Lane, and he's going to give us the Medical Executive Committee meeting and consent agenda. Dr. Lane, you have the microphone.
I have to unmute. Thank you very much. Dorothy, can you put up our screen, please? So this is from our MEC meeting that we did a week ago in the morning. And let me wait till Dorothy puts this up. Dorothy, you can be able to put that up?
I'm sorry, I was on double mute. I'm sorry. Sarah, can you grant me access to share my screen? It's granted. Thank you.
So the first 14 items were part of our annual plan approvals. There were no changes. We need to approve them on an annual basis. There was no discussion beyond approving them, and MEC approved all of those unanimously. Then we had 2 policies with changes: peer review, professional practice evaluations. These are when there's a concerning case and we have someone do a peer review on another practitioner. The only real changes is we more clearly defined what is a major and a minor deviation. We thought there were some concerns before where there was a major deviation in the care but without any bad outcomes, and people were classifying it as minor. And just because there's no bad outcome, we wanted to clarify what constitutes a major and a minor deviation in care. And then the next one was RNA, which is registered nurse first assist. These are specially trained nurses that can assist surgeons in the operating room. And this was to clarify. This was to put the policy together and went over things like they need 3 years of experience, what certifications, who's supervising them, what training they needed, and procedures that they're allowed to do. And then the next two was psychiatry and radiation oncology. And both of them were, again, clarifying what certifications you need, what kind of training or residency, previous experience. And then they both delineated the privileges that each one could perform. And these were all approved unanimously by MEC with no changes or additional input. Any questions?
I'd like to just interrupt you for a minute. Somebody has some rustling going on. So can you make sure that your speaker is muted while someone is talking? Thank you. So Dr. Lane, do you have further information for us?
This is Director Barnett.
Can
you hear me?
Go ahead. Yes.
Oh, I just wondered, in the emergency operations plan, if the telephone numbers and all of the other data listed in there are updated year to year?
You know, I can't answer that. Shawnee, are you aware of that?
Yes, I can answer that, Dr. Lane. Yes,
okay.
These are reviewed. The Emergency Management Committee that reports to the Safety Committee for our organization reviews and approves these policies and updates any phone numbers as needed.
And then I neglected to mention that the last one was respiratory illness clinic, which is it's a new thing that we've had since COVID. And this just defines what nursing interventions they can do, procedures they can do, and so it just more clearly goes over the RIC, the respiratory illness clinic.
Just one comment as a new director, and reading through these plans, they are extremely detailed and really valuable guides, and I'm impressed with our hospital that we have these types of plans in place. They certainly are reference documents that give us the opportunity to go back and look when I think questions come up. So, I have to say they're quite extensive.
Yes, they're really extensive. And Janet, I think your group deserves the majority of the credit on these. Is that correct?
It's a team effort, of course. I just help coordinate and make sure you all get them and approve them. So thank you.
Just a point for you, Director Barnett, is that these plans go through multiple levels of review and approval, starting from the unit all the way up to the department, and then quality, and then to the board for approval. So many eyes have gone through these plans.
Director Wong, Dale Chamberlain here. I may be premature in my request, but I would like to pull the risk management plan from the consent calendar for further discussion at the end of the meeting.
I'm sorry, can you say which?
It's item 12.1.D, Delta, risk management plan.
That's under our consent calendar?
Yes.
Okay. When we get to that item, we can do that. I don't know that it's on our agenda.
Chair Wong, that's part of the medical staff's executive committee agenda.
Yeah, so
it's under
Dale,
the
that's what I'm
annual
saying.
plan approval.
I don't know that we can pull that, can we, Janet?
No, because that's the medical executive committee's approved report, but you can ask a question, Director Chamberlain.
Well, then if I may ask a question about it right now, that as all these plans state, Bob, and you've noticed it, I'm sure, and others do too, the board is ultimately responsible for these plans. We delegate this policy development and implementation to the CEO, and the CEO in turn delegates responsibility for to various individuals who sign at the bottom of these plans and policies. So I would like to have in our record here that do these individuals who sign these rely on others outside the hospital, such as industry associations or specialty legal counsel, to assist in keeping these policies both relevant and up to date? And I'm just hopeful that perhaps Harry or Janet or Dr. Lane could tell us, just in a narrative sense here, a little bit more about who they rely on for keeping these policies up to date.
I'm happy to answer that, Director Chamberlain. All of these plans or any of our policies are generally the first regulatory agency that we make sure we're compliant with, that may or may not mandate a regulation or a policy is put in place, is CMS. So the Centers for Medicare and Medicaid Services, the COPs, which are conditions of participation. As a hospital district, as a hospital, we need to be compliant with our CMS COPs. In addition, we have our state regulations. In California, that's Title 22. In Nevada, at our Incline facility, that's Nevada Revised Statute and Nevada Administrative Code. So first off, we need to make sure our policies are compliant. In addition, all of us, including our medical staff, we have associations that we're affiliated with. So the Quality Plan, there's the National Association for Healthcare Quality that I utilize as a reference. We have the Nevada, the National Rural Health Association. We have our California Hospital Association. Risk Management has an association called ASHRM. So there's a multitude, pretty much every specialty, whether it's medical staff or in our departments, has an agency or an association that we affiliate with, and we always review those in reference to make sure that we're compliant and up to date and following standards of care and practice. I think that Chair Wong mentioned to the board that all policies are reviewed by a multitude of people. I may manage the QAPI plan, the Quality Assessment Performance Improvement Plan, and Risk Management Plan. However, that also goes through med staff quality, board quality, medical staff, medical executive committee. There's a multitude of individuals that review these plans and make sure they are, again, following standards of care and practice and are applying, are in compliance with regulatory standards. Did that answer your question, Director Chamberlain?
Yes, it does. And in as much as I say, the board is ultimately responsible, I will sleep better tonight.
Good. So that, to answer your question, is a regulatory standard that the board is ultimately responsible for all policies and procedures and plans. That is a regulatory CMS condition of participation. Thank you.
Director Chamberlain, are you okay with that? I noticed that Janet mentioned all of the national organizations, but also remember that we get an accreditation from HFAP, and they're looking at all of these plans as well. And we do them annually. And the most recent thing that I've noticed on all of them is that statement of risk, if we don't comply with it, what the risks are for the organization. So again, you know that all of these policies are trying to protect the safety of our patients. Okay.
And HFAP is our CMS COPs. That's the Healthcare Facilities Accreditation Program is making sure our organization is compliant with the CMS conditions of participation.
Yes. But Alice, I hope you understand that from time to time, I think it's valuable to have that in the board minutes, in this case, the board recording, that the question was asked and answered.
I understand now why you asked that question. Thank you again, Dale, for clarifying that.
Yeah.
Okay. All right. Then what we need is a motion to approve the consent agenda of the Medical Executive Committee.
unless there's any public comment about this one particular item.
Yes, thank you so much. Are there any public comments on the consent agenda by the Medical Executive Committee? Again, I can't see any audience hands. So, Sarah, can you help me? Are there any hands up that want to speak?
Not that I see.
Okay. Having no audience input at this time, can I have a motion to approve the Medical Executive Committee meeting consent agenda?
This is Director Barnett. I'll move to approve the Medical Executive Committee consent agenda as presented.
I'll second. Dale.
Okay, so it's been moved by Director Barnett, second by Director Shamlin, to approve the Medical Executive Committee meeting consent agenda as presented. A roll call vote.
Director Barnett,
Yes.
Director Brown,
Yes.
Director Chamblin,
Yes.
Director McGarry,
We do need an audible vote
Yes.
for this item.
Chair Wong.
So the consent agenda has been approved as presented. Thank you so much, Dr. Lane, and thank the team for reviewing all of those plans, policies, and procedures.
Absolutely. It's certainly much easier to review them than to write them. So I'm glad we're not doing that.
Moving on to item 13, this is the consent calendar, and these are expected to be routine and non-controversial. There are 6 items that are reports in general, resolutions regarding our teleconferencing, minutes, etc. Does anybody on the board want to pull any of these items for further discussion? I see no hands or hear no voices. Is there any staff member that wants to pull an item for further discussion? I see no hands. So what we need now is a vote on accepting the consent calendar as presented. Can one of our directors give us a motion, please?
Yes, Alice, I'll move approval of the consent calendar.
A second from one of our directors?
I'll second, Michael.
Okay, so it's been moved by Director Brown, seconded by Director McGarry, that the consent calendar be approved as presented. I think we have a vote.
Director Barnett,
Yes.
Director Brown,
Yes.
Director Chamblin,
Yes.
Director McGarry,
Yes.
Chair Wong.
The consent calendar is approved as presented. Moving on to actions for the board, we have a resolution 2022-05. Dylan Crosby, our Director of Facilities and Construction Management, will present that.
Yeah, thank you, Chair Wong. So the item being considered here in this resolution is Bill Rose Park. Bill Rose Park is located on our campus, roughly in the southwest quadrant of our campus, bordered by our child care center, across the parking lot from our skilled nursing facility, as well as the Western Addition, and then bordering some homes on Lake Avenue. The Bill Rose Park is currently owned and operated by the Truckee Donner Parks and Rec District, and of which they're considering the disposition of the property. In doing so, and as we've looked at with our master plan, this property is a very important and essential piece to our master plan, and really directly supports our goal as a district and as an organization to improve access to quality, affordable health care. You know, more specifically in staff's intention and the envision of the master plan, you know, this parcel's envisioned to be utilized to improve access to our campus, improve parking and wayfinding, as well as remove some safety conflicts that we have just with pedestrian and traffic conflicts. So it directly expresses our mission and values. of which, and due to both the Parks and Rec District as well as ourselves being public entities, we are subject to the Surplus Land Act. The disposition from the Park District, and if we were so gracious to be offered the land, would be considered exempt surplus land. As the master plan is currently not entitled through the Land Use Authority of the town of Truckee, it requires written findings from the board, which is stated in the resolution, that supports and shows that the parcel in question furthers the district's purpose of providing access to quality and affordable health care. To add on that, we also recognize that the Bill Rose Park has an important place for the community and the utilization therein, as well as the memorialization of the Bill Rose name, which staff have deeply considered, as well as talked with the Rose family in consideration of the master plan and some of our intended plans with the master plan, of which we intend to memorialize the Rose name with a new arterial roadway that we're proposing on the west side of campus, as well as memorialize the Bill Rose name in our healing garden, which will be, or is envisioned to be essentially right in the middle of our campus, right off the western addition, and very adjacent to the current location of the park. I hope that provides a little bit of background and here. And Harry, I don't know if there's anything you'd like to add on to that before answering questions.
I think you did a nice summary. It is vital that we go through this critical finding relative to our master plan and the safety issues and our need to further our public health and safety needs, so that this facilitates Parks and Recs doing the next proper steps on this complex ground transaction. So he explained it nicely, and I think the resolution outlines the findings. And so staff is requesting that our board approve this resolution so that we can begin now then immediate communication to the Parks and Rec District, and they can take critical next steps so that our master plan can properly be implemented.
Anybody have any questions or comments or have for Dylan or anything about the resolution? Dylan, did you want to?
Do I understand correctly? You'll come back to us with the purchase price, or if are we purchasing an alternative piece of land to offset what the park is losing?
The board has given us authority up to X dollars in a private, in a different setting. And so, we believe that's sufficient room to complete this transaction.
Okay.
If I can just provide a little background through the chair.
Yeah.
So the Surplus Land Act applies to all local governments, and it basically says anytime a local government wants to sell its property, it needs to, unless it's exempt land, it needs to notify Department of Housing and Community Development so that it could potentially be used for housing. So it's really a law that tries to incentivize development of further housing. But it doesn't apply in certain circumstances, such as when a local agency is selling it to another local agency for use by that other local agency for its statutory purposes. And so that's what this finding is. It's just saying to the Parks and Recreation District, if they wanted to dispose of this by selling it to the district, it would be exempt. It wouldn't be something you could build housing on because the district would be using it for its district purposes. And from what I understand, this is not a location that's conducive to housing in any sense because it's very small and landlocked.
That's what I wanted to hear and have the board understand that it was what the resolution was for. So any further questions about this property and the resolution? Anything from our audience? If not, then we need to have a vote by the board to approve the resolution in regards to resolution 2022-05.
So moved, Dale.
Second, please.
Second, Director Barnett.
Director Shamlin moved and was seconded by Director Barnett to approve the resolution 2022-05. Could I have a roll call vote, please?
Director Barnett,
Yes.
Director Brown,
Yes.
Director Chamblin,
Yes.
Director McGarry,
Yes.
Chair Wong.
Little steps on getting this property, so thank you so much. And the vote has been approved and the resolution has been approved.
Thank you for your support. Appreciate it.
Thanks, Dylan. We'll move on to 14.2, the fiscal year 2023 to 2025 strategic plan. And we've got our CEO and Judy Newland, our COO, to present the strategic plan or a summary of it.
Thank
Harry,
you,
would you go
Director
first?
Wong. I'll go ahead and get started if that's okay, Harry, and then I'll give it to you at the end. So again, this evening is presented before you to consider approval of the fiscal year 23-20 through 25 strategic plan. And just a reminder, this plan includes our mission, our vision, our values, our board of directors guiding principles, and the priorities and objectives that make up the strategic plan for fiscal year 23 through 25. Just to remind you, this has actually been an 8-month process. The process began in July of 2021, where we began to collect data. We interviewed our staff. We did surveys for our staff and our medical staff. There were interviews that occur, and we collect quite a bit of data to learn more about what opportunities we have, what concerns they may have, and just what kind of services we're currently providing. In August, if you recall, we had a kickoff meeting, a retreat that include board members and any community members that were interested in our executive team and medical staff to begin the strategic planning process and learn more about the current and future state of our healthcare. Once that was completed, we developed a strategic planning task force. This included 2 of our medical staff, Dr. Lane and Dr. Skousen, along with 2 of our board members and our executive team, to really begin to take all the information we have and to draft and develop our strategic plan. And just so you all recall, our strategic planning task force actually met about 4 or 5 times, and our executive team met about 14 times to really draft what you see today. So I'm here to answer any questions, or Harry, if there is anything else you would like to add.
Judy, I think that was an excellent summary, and staff does bring it forward today as a very thoughtful guide for our next 3 fiscal years. And we appreciate the board's input, the medical staff's input, our general staff input, and other data sources. And we're excited to have the board consider it this evening and approval of it, as well as a critical guide, so that we have timely approval that relevant items can be considered in our budget process that will be brought forward in just a few months for fiscal year 23. And it'll be a guide to our 10-year financial forecast of revenues and balance sheet and so forth. So we bring it forward for your consideration and approval this evening.
Does anybody on the board have any questions? I know we've reviewed this, and I don't know if you've, if any of the document can be put up on the screen to be shared just for a review, but are there any questions from our board? Okay. Now, this is a document we've all been living with and breathing for the past 8 months, I think, or more. anybody from our audience that want to make a comment about the strategic plan, can you put it up on the screen, Sarah?
Just a moment. Do you know what pages of the board packet you want me to share?
234.
Yeah.
Starts at page 230 of the board packet.
Is it near? Okay.
I had to turn my mute off.
Go ahead, Judy.
I just wanted to know if you wanted to go through each page or if you wanted to go down to the green
No,
page.
just a page, if we could, just to 234, which is the strategic plan priorities and objectives. I think that's the most critical. And I really wanted to have our audience see what has been worked on and where our health system is going.
I do appreciate that, Director Wong, and really, again, the priorities really, again, I know it's already up there, but I'll just repeat it out loud. Delivering outstanding and patient and family experience is a priority, making sure we provide excellent patient-focused quality care, make sure we strengthen a highly engaged culture that inspires teamwork and joy, ensure strong operational financial performance for long-term sustainability, and expand and foster community and regional relationships. And again, really appreciate all the collaboration and the teamwork and the time spent to really assure that we have a strategy for our future, for our health system, make sure we meet the needs of our communities, of our staff, of our partners in healthcare throughout our district. And that would include, our Incline Village Community Hospital, our North Tahoe services, Tahoe Palisades, and within our Truckee region and Donner Summit. Along with really understanding, we also have a responsibility to support those rural communities north of us and how we can support them.
The audience has been able to view what those strategic priorities and objectives are. Are there any comments or questions?
I did want to make one quick comment. I just wanted to thank Judy for engaging me back in October and allowing me to participate in this from afar. So I just really thought that was a great experience, and I just want to thank Judy for having the foresight to allow me to get involved and immerse myself in the health system by participating with the strategic plan.
You're welcome.
Another hand up. Gail Shamlin, you had a comment?
Alice, now that we have the plan, do we also have a plan to revisit this on a regular basis, perhaps quarterly, to measure our progress and success in meeting these obligations?
Judy or Louis, do you want to make a comment since you're the drivers?
I think there was a plan that the board actually made a recommendation maybe to wait about 6 months from right now was your guidance a week or so ago, and then we bring it forward quarterly after that if that's still the wish of the board.
And I think that at the last meeting that we had, we weren't going to see it until 6 months from the implementation of it, so that we had some data to bring back to the board.
I wanted that in the board record.
So this plan begins July 1 of 2022. And so that 6 months should be sometime in December. And the nice part about having this done at this time, it allow us to prepare in our budget anything new that we anticipate that we need to budget for fiscal year 23.
Gail, the minutes will reflect. Any other comments? We need a motion to approve the strategic plan as presented.
I move to approve the strategic plan as presented. This is Director Barnett.
I second that motion.
It's been moved by Director Barnett, seconded by Director Brown, that we approve the strategic plan for 2023 to 2025. Can we have a roll call vote?
Director Barnett,
Yes.
Director Brown,
Yes.
Director Chamblin,
Yes.
Director McGarry,
Yes.
Chair Wong.
Yes. So the strategic plan as presented has been approved by the Board of Directors. And we will be hearing reports in December on how things are going. We'll move on to item 15, and this is for board discussion. It's an item that I think we've been waiting to hear about. We've got Maria Martin, who's the Director of Wellness Neighborhood Community Health, is going to present the review of the results of the recent community health assessment, needs assessment.
Sarah, can you grant me sharing privileges?
Lizzie or Maria?
Lizzie.
So while Lizzie's pulling that up, I just want to thank you for the opportunity for Lizzie and I to present a summary of the results of the 2021 Community Health Needs Assessment. I am the Director of Community Health and Wellness Neighborhood, as you mentioned, and Lizzie Hennessy works in the Wellness Neighborhood and is our Population Health Analyst. So tonight we're going to be talking about a summary of the results, and we're also going to be talking about accomplishments that we have achieved from our Community Health Improvement Plan, and that was the comprehensive 3-year plan that we developed after our last needs assessment in 2017. Okay, so the purpose of the Community Health Needs Assessment is to help us identify strengths, gaps, and opportunities in meeting the health and the healthcare needs of our community. We complete the assessment every 3 years as part of the Affordable Care Act. And the data from the assessment kind of forms the foundation for a community improvement plan, a community health improvement plan that we will develop and work on moving forward. And doing this process, and it helps us to demonstrate our accountability and our responsiveness to the community in identifying these needs that we've identified. Okay, so I'm going to talk a little bit about the needs assessment structure and the data sources. So the first thing I wanted to draw your attention to is that there's been some changes in the demographics of our community as a result of the most recent census. And some of the factors that can impact healthcare and healthcare needs are identified there. We're seeing more of a balance in male and female community residents. We're seeing an aging of our community, more residents over 55 years old. We're a more educated community with a higher percentage of college graduates and a slightly less racial diversity from the previous census.
So we have actually been using a similar methodology since the first needs assessment conducted with Tahoe Forest in 2011. We use the behavioral risk factor surveillance survey questions, and these are standardized questions which allow us to compare to California, to Nevada, to the country. Not every state chooses every BRFSS question, so we can't always compare, or there might be a few years in between our data and the state's most recent data, but they are standardized, which is really helpful versus making up our own questions. So what we've always done since 2011 is we choose a randomized sample. We use address-based sampling because of the transit nature of our community. We don't want to use phones directly, but through addresses, these addresses are chosen randomly, and then they're actually sent a postcard that explains what this needs assessment is. They have a unique code. They could go online and complete the survey, or they could phone call the surveyor and do it verbally. If they did not respond on their own, then our surveyor would actually call them. So they could complete this in English or Spanish. And through our randomized sampling, we did more than one mailing because we did have a low response initially. But the initial mailing was in late May, and the outbound calls began shortly thereafter and went through till July. And we're aiming for around 400 adults. We're trying to survey, obviously, non-institutionalized adults. We don't survey anybody under 18. And we identify the addresses based on our service area zip codes. So we're aiming for around 400 people. We got 432, which was great. In previous years, complementary to the randomized survey, we've done focus groups to get more qualitative data, because with any surveying, there's always some sort of bias. Some demographics are more likely to do these sort of surveys than other demographics. So in the past, we've done focus groups with our low income, with our younger residents, and given everything that's been going on the last 2 years, it did not seem feasible to do these focus groups. So in lieu of that, we partnered with Sierra Community House, and we collaborated with their Promotora team to do targeted surveys of our low-income residents, knowing that we would be undersampling them with our randomized methodology. The Promotoras targeted their food distribution sites, which they have in Incline Village and Kings Beach and Truckee on different days of the week, as well as their home visits. And that data is kept separate from our randomized. You can't combine them, but it's complementary. They're the same exact questions that were asked. They had assistance. So if you had people who had a lower tech literacy, they had support there on hand to help people just understand the question, as you can see, they're English or Spanish, but just to accommodate all literacy levels. And through that targeted sampling, we had 146 low-income adults. So the red box, next to the red box, population estimate is our makeup based on our U.S. Census data. So it's a 2015 to 2019, so not the 2020 census. But they take the weight of those and use it to kind of balance out who responded to ours. So you can see really what kind of stands out here is we had low responses for our under 35 population, otherwise, and the lower levels of education. But this is ultimately what's represented in the survey as far as breakdowns by gender, education, race, age, and you can see Nevada we pulled out as well. And then you can compare that to our low-income participants. So our low-income participants tended to have a lower level of education. They tended to be lower, which is really important when you think about behaviors impacting their health outcomes. And I do want to point out, with this methodology, our goal is to be able to apply the findings of this to our entire service area. These are not intended to pull out any one zip code. If we were going to pull out any one zip code, we'd need to be surveying hundreds and hundreds of more people to have a large enough sample size to do that. So it is an important point to make.
Great. Okay, so now we'll start going into the results that we got from the surveys. The first thing I want to talk about is the focus areas. So these are the focus areas that are derived from the survey results, the areas where the data demonstrates that there is need. We've been doing needs assessment since 2011, and our focus areas have remained essentially the same. For the last couple needs assessments, we incorporated health disparities in each of the other focus areas. But this year, with the impact of the COVID-19 pandemic and the fact that we had a more robust source of data on our low-income population, we pulled out the health disparities, those metrics, to look at them separately because they were pretty compelling. And as we go through these different focus areas, we will be reviewing some of the metrics in the different areas. There's well, actually, we can probably go to the next slide and I can talk about the structure. So when we go through, actually, you can go back, Lizzie, if you want. The we're going to talk about the 4 focus areas, but I want to preface this with how we set up the structure to present the data. So we started for each area, we're going to talk about a highlight, something positive that we saw in the data, and talk about some of the factors that could lead to that positive result. Then we're going to talk about additional data points in that area. And then we will talk about the interventions that have been put in place since our last needs assessment in 2017 to reflect that same area. Okay. All right. So for substance misuse, one of the things that we saw is that we see that we have an increase in residents that experience chronic pain. And that's probably to be expected. We have an aging population. But what was really fascinating with the results is the dramatic decrease in the participants that reported that they were using prescription pain medication. Now, during this 3-year period, there's been a lot of information and outreach and news articles about the opioid epidemic. So there could be some response bias in that, and people saying no just because of potential stigma associated with opioid pain medication. But while this was going on at the same time in the health system, we were doing interventions at multiple levels within the health system to address the same issue. And this started out with really the PRIME intervention. So PRIME is our quality improvement program for the Medi-Cal population. And we had a project that began in 2016 around non-malignant chronic pain. And a lot of these changes and systems were kind of put in place as part of that project to address the opioid use. We started promoting more multimodal therapies for pain, things like biofeedback, mindfulness, therapeutic massage. We had some counseling opportunities for people who were having concerns with opioids. The PDMP and Cures are state programs that track controlled substance prescriptions, and that was put into law so that these prescriptions, when they're written, are tracked, and that was to dissuade overprescribing of opioids. We had providers implement medication agreements with their patients to talk about how often they're taking it and the requirements for that. Same with the urine toxicology tests. So when they came in, they could test the amount that they were getting. And then a lot of provider education and continuing education units around the topic of chronic pain. And also during this period of time, we implemented a medication-assisted treatment program for opioid use disorder, where there's medications provided to help people withdraw from opioids and counseling along with that. And then in 2019, the initial development of the behavioral health department. All right, so while the use of prescription medications dropped, substance use still continues to be a really big concern in our area. Our binge drinking rate remained about the same, but we're pretty high. So we're at 28% for the residents of our service area compared to the California state average of 16 or the Nevada state average of 17.2%. And this is self-reported binge drinking rates. And just to remind you, binge drinking is defined as 5 or more drinks on an occasion for men or 4 or more drinks on an occasion for women. We also saw increases in both vaping and smoking, pretty significant for our area. Interestingly, though, this brings us to the average for the state vaping rate. And then the last category, substance misuse. This is really high substance use because the factors that go into that category is either binge drinking, taking non-prescribed prescription medication, so misuse of prescription medications, or near daily marijuana use. It's at least 20 days in a month.
Excuse me, Maria.
Mm-hmm.
This is Mary. Do you want questions as we go along, or would you like us to wait to the end?
I think it's fine to ask as we go along when we have the information in front of you. If there's something that we're going to talk about later, I'll let you know, but that's fine with me.
I just wanted to comment on the previous slide and say that I thought that the decline in prescription pain medication is truly remarkable, and I think something to be applauded.
Yeah, we're calling this. Oh, go ahead.
Well, I have a question on that. I mean, when you look at the two sections, the prescription medication used for chronic pain has gone down, even though there's more reported chronic pain. But the binge drinking has gone up. So then I started thinking, well, what these people do, drop their drugs and just start drinking as a countermeasure, or are we looking at different populations and different issues?
Well, we're surveying the same random sample, but our binge drinking rate, even though it went up a little bit, it really wasn't that much different than it has been for the past few years. Some part of that binge drinking rate, I think, has to do with being in a vacation or a tourist economy, and combining that with our kind of thrill-seeking activities that people do, a lot of adrenaline-based activities. That's also associated with more binge drinking. We've seen that same trend in other mountain communities.
I also wonder, with the legalization of marijuana, I would have actually expected that number to go up a lot more because access, of course, is easier now. Mm-hmm. Any thoughts on that? When we go through like every single piece of data, we did ask about marijuana, and I don't remember the exact number that came up with specific marijuana use. It didn't jump out as super high. I was kind of wondering about the vaping use, although I think when we asked the vaping question, it was specifically for tobacco, because we did see an increase in that. What about the marijuana with the 20 a day is combined also with binge drinking and prescription meds not prescribed.
Does the prevalence of CBD derivatives factor in here too?
We did not ask specifically about that, no. The marijuana questions were more, they didn't split out CBDs versus those with THC.
Yeah.
The other comment is there's a lot of implementation. For example, the Prime interventions, which started in 2016. And I would have to think that those are partly responsible for greatly reducing prescription or non-prescription dependency.
Yes, that is correct. So it doesn't happen just from one thing. It was all these factors put together, I think, is what brought this dramatic decrease in the use of prescription pain meds. So even with chronic pain, doctors and throughout the community, people are aware of other methods to help address their chronic pain, that you don't have to go straight to long-term opioid use.
I have to see that as a really strong positive for the Prime program and also, exploring other ways to control chronic pain.
I think key to that is the medication-assisted treatment program. Now you have options to wean off of opioids. And so the medication in tandem with the therapy and the counseling is really key to helping people get off of, experiencing opioid misuse.
Well, that looks like it's going well. That's what my takeaway is.
All right, let's go to the two from here. So these are some other interventions that have been put in place since our last needs assessment. So we talked about the medication-assisted treatment program for opioid use, but we've also have this ED Bridge program, which is along those lines, where someone who is withdrawing from opioids can come into our emergency department and get started on the medication that would ease their withdrawal, and then get referred into our medication-assisted treatment program. And then in 2021, they've also added medications for stimulant use disorder and alcohol use disorder. And so there's also, we have with the Behavioral Health Department, more therapy around substance use disorders. We've increased our screening and brief intervention about substance use. And that was one of the other metrics in the PRIME program. Recently, in 2021, they've hired a substance use navigator who's based out of the ED and will deal with our patients that come in and get them connected to services. And there's been continuing provider education, Project ECHO, which is kind of like a peer-led education collaborative where people share case studies and talk about how they're treating different patient populations. And so it's been really popular for this as well. And then in the community, we've continued our awareness campaigns around alcohol awareness, and we do that each year in April. We started that in 2018. We continue to support an alcohol EDU, which is a prevention program in the local high schools, and we added a prescription drug module to that. We support the prescription drug take-back events. That's getting the non-used prescription drugs out of the house so they aren't misused by someone else, in partnership with the Future Without Drug Dependency Coalition. And around the health systems, we've improved our smoke-free signage. With naloxone to counteract an opioid overdose is now available throughout our community. And we've done not only education on marijuana in pregnancies, but we've created brochures for patients about marijuana use in pregnancy.
Maria, have any of the clients been referred to groups like Alcoholics Anonymous, drugs?
Mm-hmm. Yeah. So when they're talking with probably the Behavioral Health Department, there's lots. Yes, there are quite a few local AA groups. We do not run any ourselves out at the health system, but there are other options for that in drug treatment programs. Okay, and then we'll move on to mental and behavioral health.
All right. So our next big topic, dovetailing on substance misuse, is mental and behavioral health. So we took this opportunity with this most recent survey to ask some questions that we had not asked before, that we didn't have any way to really get the information. So this highlight is really on the perception of mental health in our community. And this bar is a statement of those who agreed that mental health and physical health are equally important to my well-being. This middle one is, I agree that Tahoe Forest Health System treats mental health and physical health as equally important. And then this last one is if the respondent had ever been asked by their primary care provider about their mental health. And what I think this shows is our community believes obviously mental health is important. We're a super active community, but a part of being so active is a recognition, and we've seen this in the Olympics, that your mental health can help you perform as an athlete. So I think that's in this. And I think there's just a little lag in that our mental and behavioral health department is really new, and our PCPs are starting to ask their patients consistently at every visit about their mental state. So I think this is a really interesting snapshot in time, just looking at the 2021 responses. And some history here is, again, the PRIME program, and that was the program that really launched annual depression screening of Medi-Cal patients. And the more recent screening at every visit really was able to build on that foundation. And again, this development and expansion of the Behavioral Health Department in 2019, not only did we hire our first behavioral health intensivist in 2019, but now we have 4 behavioral health intensivists in a short amount of time. We're able to kind of get ahead of the COVID pandemic, and the mental health needs that you will see in the next slide have been a bit exacerbated. We have secured funding for the Behavioral Health Department, and we oversee and manage that funding. And then, as I mentioned, this, and then again, the shifting to every visit. So just like your blood pressure, your mental health, we can screen at every visit. These next stats are not as uplifting. As you can see, in every area that we have here, we have increased need for mental health. Our anxiety levels increased. Fortunately, those seeking services for counseling increased as well. Those who responded as currently depressed, which was 8 questions, and how they responded to those questions graded them as being currently depressed. Having been diagnosed with a depressive disorder increased, and having at least one poor mental health day in the last 30 days has increased. So the COVID-19 pandemic really exacerbated all of our mental behavioral health indicators, unfortunately, so that 1 in 5 of our local residents actually has had a depressive disorder diagnosis. And how do we compare to the state and both of our states, California and Nevada, for depressive disorder, which is the one that we can pull that information? We're 19.5% compared to 14% for California and 18% for Nevada. So we are higher than both states. Anxiety disorder, unfortunately, we can't get state comparison, but around 16% for our local residents. But what have we done since 2017? We have done a lot of work to really support our behavioral health department. And just in the last 2 years, we're in our 3rd year, we brought in $1 million to support directly behavioral health services within Tahoe Forest. And that funding has increased our mental behavioral health providers. It does not fund Maria or me. And we have really strived to bring consistency in education through facilitating multiple groups to provide education and follow up. And there's so many details that go into bringing this consistency to such a large health system that it's just been really great to be part of a team. And you can see that we are on the right path. And it's just really reassuring that we had some of these services in place prior to 2020. In addition to all the depression stuff in primary care, we launched the Zero Suicide Initiative to increase awareness on safer suicide care. And this is a collaboration with the state of Nevada. So we've been able to have guidance from the state for, oh gosh, it's like 2 years now, Maria.
Yeah.
And we collaborated. Harry sent out a survey on behalf of the Zero Suicide Initiative to get baseline data. And so we've been able to really make some improvements there around education for staff and consistency in our policies and our practices and that sort of thing. And we are part of ensuring that, at least for our youth, that there is follow-up if they are seen in our ED for a 5150, a crisis evaluation, a crisis assessment. And we're working through the planning with for adults. On the community side, we have been part of the Leadership Council for the Suicide Prevention Coalition for many, many years. That's the school district in both counties and the local collaborative. Again, we've worked with that coalition to do education throughout the community. The school district has done a lot of education and making sure every student has touch points. And for us, you guys are probably aware of the peer support, and we have a health stream module called Talk Saves Lives that we've rolled out, and the in-house multimodal services, therapies, and resources like the there's the podcast that we have for staff as well. But mindful-based stress reduction is offered here within the health system, nature-based therapy through our support with Gateway Mountain Center, and focusing on increasing positive, healthy behaviors that are such simple things like exercising and eating well through our Authentic Wellness series. And then a part of all of our grant oversight is a behavioral health advisory group to make sure we're getting that feedback from our community partners and implementing that into our clinical practices.
Okay, so now switching to chronic disease. Some positive things we saw was a slight decrease in the incidence of diabetes and a slight decrease in self-reported BMI. And that's positive. Both of those factors, have a big impact on a variety of chronic diseases, and chronic diseases, are one of the leading causes of death and disability across the country. So what we've done, to address chronic diseases, really a lot of it has to do with our supports for our patients that have chronic diseases. A little bit on the prevention end too, we'll talk about. But we've been implementing self-management programs since 2015. Those were the 6-week evidence-based program. It was out of the Stanford School of Medicine. We started with chronic disease and diabetes classes, and we've expanded since then. Chronic care management is part of the care coordination group, identifying those patients with multiple chronic disease and providing additional resources and supports for them to help them manage their condition. One of our prime project was the Million Hearts Project around cardiovascular disease. And then we also added in diabetes and behavioral health a little bit later. And then our prevention program, which we started in 2018, we first got certified with the CDC to offer the diabetes prevention program. And that is the first prevention program that is reimbursable through Medicare and now Medi-Cal for those who do not have diabetes yet, but are at very high risk for developing it. And then we can go on to the next one. So the other indicators are a little bit mixed. Even though we saw a decrease in our BMI, our BMIs are still high. We're better than the state, but we're still almost 50% of our residents are either overweight or obese. We're at 46%. The state average is 64% for either overweight or obese. We talked about chronic pain already. And then for high blood pressure and high cholesterol, we saw some increases in that from 2017 data. Not a lot, but some. So some other interventions that we've implemented since the last needs assessment is the support for the affordable lab screening. People that need to monitor their lab values and maybe do not have insurance, that's a route for that. We've seen an increase in the utilization of outpatient medical nutrition therapy, and that's something that we've really advocated for, and to help people with all chronic diseases. And we've seen an expansion of our bilingual health promotora team. And the promotoras were initially brought in to work one-on-one with the care coordination team. We had one and we expanded to two at that time to really support those patients with multiple chronic conditions. The promotoras assist the patients in navigating the health system, help them really understand and follow their treatment plan that's prescribed by their provider. They connect them to resources to address non-medical factors that impact their health, whether it's housing or food assistance or other factors. And then they also provide a lot of culturally appropriate health education for that population group. And so while I said we started with the promotoras working with specifically patients with multiple chronic diseases, now we've expanded into some other targeted areas as well. So we have a promotora working with the cancer department. We have a couple working in behavioral health and supporting those patients. We have one focused on the pediatric high-risk population and one in the perinatal population as well. And then in our community outreach, I talked about starting with the self-management programs with diabetes and chronic disease. And then we've also added chronic pain, building better caregivers, which is targeted for people taking care of someone with a chronic condition. And the newest one is Cancer, Thrive, and Survive for people with cancer or cancer survivors. We continue to offer the diabetes prevention program, both in English and Spanish, with multiple cohorts going simultaneously throughout the year. And although we cut back a little bit on our community health screenings, this is something that we're trying to get back into when we're out in the community and have the opportunity. We do random blood glucose screening and blood pressure screening, and then trying to connect people back to primary care for those that are high.
All right, on to prevention and wellness. So these graphs are showing how physically active we are as a community. This first graph is the percentage of respondents who have exercised for at least 30 minutes 5 times in the last week, and we increased from 2017. And this one number is, I want to say 94%, 96%. This is the percentage of respondents who have exercised in the past month. So staying pretty even there. This one is showing times per week. So since 2017, how often people were physically active increased, which is great. And this is the first time we asked this question, but I like it because it's showing that our respondents are getting outside every other day, which is being outside is so great for your mental health. So I thought that was an interesting one to share. And some of the history there, these are some of our longest running programs. Be Fit is I'll just say physically active program that is complementary to Harvest of the Month that launched in our school district back in 2011, all with parent volunteers or grandparent volunteers or uncle family volunteers. We also facilitate community fitness challenges like walking challenges, hydration challenges. We have free community exercise classes with the the Family Resource Centers back in 2012. And physical activity is really embedded into all of the chronic disease programming. The self-management programming Maria was mentioning has physical activity as a key part of it. The diabetes prevention program has physical activity just ingrained into how the programs are run. And then we are thinking that based on the just the free respondents, we ask what is, how would you describe our community in one word? People say active and fit and outdoorsy. And so we're thinking this is some of the reasons that attracting newer people, new residents to our area is just because of the culture. And here are some other prevention and wellness data, largely around clinic visits and flu vaccine and COVID vaccine. So visits decreased. People went to the dentist less compared to 2017. People had their physical exams less from 2017. I doubt that surprises anybody. However, our flu shot increased from 2017, which is a positive. And then because we asked people who had already received their vaccine, and we're 84% here. So that was great too. We're better, a little higher than the state, which was 70%. So those are all positive health behavior indicators. We kind of have a lot of stats in this area. These are some new questions that are getting to questions we can't really get we can't really extract this data from our EMR. Like the question around supportive relationships is, do you have somebody to whom you can confide in? Do you have somebody who can help you do household chores if you need them? And so it was really great to see that our community really has a lot of support. So 97% of people have at least one person that is a supportive person in their world. And these others are experiencing nature, access to mental health care, regular physical activity, quality sleep, and balanced nutrition are all really basic things that keep us healthy overall. And some of these are so basic, but you can see we have, even for regular physical activity, the 5 times a week can be a bit much if you're working and, everything. But the 2 that are really important to point out are this quality sleep. And how we asked about quality sleep, we didn't ask people how many hours they slept. We asked them about I think there are 4 or 5 questions on how they felt, if they woke up during the night, if during the day they felt drowsy. So getting at those indicators that are showing that they're actually not getting quality sleep. And then the balanced nutrition was, Maria's a dietitian too, so it was a little sad for Maria. We have some, we're hoping that would have gone up because we'll show you another stat later about meals at home.
Lizzie,
yes.
Here, with a question on exercise and health. It's reassuring, but I also thought we might have taken a dip last year when so many gymnasiums closed due to COVID. Obviously, people see alternatives, outdoor alternatives. Bicycle sales are just off the charts. And I'm out there myself, so I see a lot of hikers and other outside. But it's interesting to see that people have adapted their exercise routine, I'm sure, to accommodate the fact that the gyms are closed.
I agree. I mean, everything was closed, so I think it was the one thing you could do.
Well, it's interesting to look at the BMIs and then look at how they describe our community, because you would think that people who were exercising and active would have lower BMIs.
Yeah.
Maybe it's not the, we have room for improvement with the consistency of it, the 5 times for 30 minutes. But I also want to share that this isn't the question we say I think we tried to use physical activity in reporting this out. The question doesn't ask, do you exercise? It's, it's actually really, gardening falls into physical activity. And, the question's really well done. It's not like you're going to a gym for 30 minutes. It's like, are you getting out and walking 2 blocks to your neighbor's house versus driving? I mean, that's not how the question is, but it's a really well done question.
Yeah.
I was thinking that the visual perceptions around our community are misleading in the sense that everybody who's active is out there and you see them. So if you go on the trails, you see other people on the trails. If you're running on the bike paths, you see other people running. And if you're skiing, you see thousands of people out there skiing. But the ones that we're not seeing are the ones who are sedentary and don't get out. And so, there's obviously a group of people that aren't hitting the trails and the slopes and the different available things that our natural surrounding provides us. So I think, it's slightly misleading, because if you're active yourself, all you see is other active people, so you think everybody's active.
Yeah, right. Yeah.
Mm-hmm. Yes, that's true. And it gives us the opportunity to find other ways to try and engage people to get outside. I think a lot of research is showing just the benefits of being out in nature, walking and being around the trees and breathing that fresh air in terms of stress reduction. And that's something that could be accessible to anyone up here, whether they're being active during that or not. But that's just one of the things that we can try and focus on.
Yep.
All right, so this next slide is taking the percentages from the randomized survey and saying, okay, what does this look like in terms of numbers of people who live here? And the reason why this is important is because it's the number one thing affecting nearly 28,000 people in our service area is not eating enough vegetables. Followed closely by experiencing any trauma symptoms. The trauma series of questions is similar to the sleep one in that you ask about symptoms of trauma. So you do ask, have you experienced, and it has a wide range from war to abuse to being part of a natural disaster. Have you experienced trauma? But then it has this other series that asks if you have experienced any of these symptoms. Again, focusing or impacting like 23,000 people in our community. So the top 7 are actually the top 7. And then we wanted to show some of the others. So these aren't just the top, I think there's 10 or 11 on here, but the top 7 are the top 7. And then economic hardship, I want to say is
number 10.
Is number 10. And then does not have a PCP was number 15. So that's there are a few in between here, but we just thought these are really important because the PCP is such the bridge to so many things in our community. Substance misuse we talked about is 10,000 people. And then the binge drinking, even the binge drinking is actually number 19. If we were to list all of these, they will be in the big report. But for here, we want to show that binge drinking is, 8,600 of our residents. So this is kind of an interesting one.
What's the general population in our service area?
Let's see if I have it here. 29,962 people.
We can round it off at 30,000?
Yes. Plus or minus. So the standard of error here is plus or minus. The estimated error for these estimates is around 3,817 adults.
Okay.
Would you guys like to? It looks like some of you are really looking at this. So
I had heard the number 41,000 for our hospital district. So what are we? Why are we the different number?
We use the American Community Survey from the U.S. Census Bureau for our numbers, so I can't speak to where the 41,000 comes from. That could be a more recent number because you do have a lot more recent residents. But we use the 5-year estimate from 2015 to 2019 because the 2020 data wasn't out. And anyway.
Okay. All right. Well.
All right, I'm going to move on. So since the 2017 needs assessment, some of the things that we've done is supported the health food choices at the hospital cafe. We've continued the Tahoe Forest produce program for our employees, which is twice a year and reaches dozens of employees. We've developed family-centered lifestyle program for pediatrics, so kind of not just the nutrition, but the behaviors that go around with having a healthy lifestyle. Increased utilization of nutrition counseling services for chronic disease, pediatrics, endocrinology, and obstetrics for those with gestational diabetes. We have done physician education on the HPV vaccine in collaboration with UC Davis. We've trained our medical assistants on the application of fluoride varnish with our local pediatric dentist, Dr. Gustafson. And we have most recently developed a plan to implement ACEs screening and trauma-informed care into clinical practice, starting with a pilot in our pediatrics clinic. Again, going back to the trauma, and we saw there's a lot of people with those trauma symptoms. In our community, we have supported community walking challenges and meetups to walk with people, so you're not walking on your own. We collaborate with both our Placer and Nevada County to offer free vaccination clinics every year. And we facilitate the Truckee Tahoe Immunization Coalition, again, going on for well before our time. We've organized school-based dental screenings and linked students with dental providers by providing the follow-up care really with our Promotora team to make sure all of those who had early evidence of caries in their mouth, they would call the parents and link that individual up with a dentist. And we are facilitating the ACEs network of care, which is the school district and the hospital and the counties and the collaborative and Gateway Mountain Center, and making sure that we are being comprehensive in our trauma-informed approaches. Now
okay, so down to health spirit. Now, as Lizzie described before, we approached the getting this information on our low-income population in a different way this year by being able to really target those people that are clients of CR Community House. So really going to where the low-income population is. And because we got more detailed information than we have it from our previous year focus groups, we're really able to look at the data and compare it to our random sample. And so we're going to look at the disparities around preventive screening, access to care, and health conditions and behaviors. All right, so this first one, the blue is the random population and the purple is our low income targeted survey population. And what we see is really large differences in the percentage of those respondents that are seeking preventative care for cancer screenings. The mammography rates, they're probably the least disparate of the two. There's a lot of national attention around breast cancer screening. We have multiple funding sources available for people that may not have any access to any health insurance. And it's the most minimally invasive screening test compared to the ones that we asked about. Colonoscopy is a huge disparity, and that is kind of a known that there are racial disparities in these types of screening. Latino men are less likely to engage in preventative screening, which means that when they're diagnosed with colon cancer, it tends to be at a more advanced stage. And interestingly, in the Hispanic population, people are more likely to be diagnosed at a younger age for colon cancer as well. So that's a huge issue. And then for the PAPS test, which is a test that can screen for cervical cancer, 85% of women who die from cervical cancer have never had a PAP test. And Hispanic women experience the highest cervical cancer incidence for any racial group in the U.S. So when we see those patients, they tend to present with more severe cases when they're first noticed because they're not doing the regular screening. So how are we going to address this? Well, we have some things in place to promote preventative screening. We have the promotoras that when we're out in the community and going to health fairs and stuff, we do provide a lot of screening information and really trying to get people in for preventative screenings. We have these are the additional supports that support uninsured or underinsured women around breast cancer screening and breast cancer and biopsy and testing. And then one thing to look forward to is that the PRIME program has now transitioned to the Quality Incentive Pool program. Again, it's a Medi-Cal targeted program, but this new program has more preventive screening metrics in there. And so we are going to be tracking mammography and cervical cancer screen as part of that intervention. Okay, the next area that we saw disparities was in access to care. So our lower income residents were less likely to have a physician that they would consider their primary care physician and less likely to be insured. And that was a pretty dramatic difference. At the same time, they're more likely to experience barriers like a language barrier and particularly a literacy barrier. And that we see that a lot of that with our promotors, the clients that they're working with, literacy level is a real huge barrier for care, understanding, and being able to move forward with their treatment. They also experience barriers around transportation and being unfairly treated in a healthcare setting.
Quick question.
What does that mean, unfairly treated? What constitutes unfair treatment?
Yeah, that was an interesting question. It was one of the, it says, we are interested in knowing whether you have experienced any unfair treatment because of your race, ethnicity, or cultural background. Within the past 12 months, have you felt treated unfairly when you were getting medical care?
Oh, okay.
I think that is an important one to really look at. I mean, most of the other data that you've presented on this slide, I think we knew. It's nothing new to us as a healthcare provider, but the fact that they're able or willing to say that they were unfairly treated, I think is important, and to follow up on what is it? Is there a trend in it? Is it their perception or is it true?
Yeah. Right. Yeah.
Mm-hmm.
I'm also looking at this low literacy number here. That's over 50%. That's striking. So that means there are people that basically don't even have grammar school educational equivalents. Is that what we're seeing?
Yes, that is true. Yeah, I think that's been a little surprising to us, but from talking with our promotores, there are many patients in our community that are Spanish speaking, but do not even read in Spanish. Wow. So they're not literate in English, but also not even in their native tongue.
So translating information into Spanish is not going to help those people.
Well, it helps them to translate it because they can understand that, but written information in Spanish is a barrier. And so, like as an example, we have a few cases where our promotores have drawn pictures on the medication to remind the patient which ones to take in the morning and which ones to take at night.
That's very enlightening to know that.
Yeah.
On transportation, has TART, now that it's free, been useful to low-income people?
I think the transportation options have improved from the past, but sometimes transportation can still be a barrier. I mean, it's still hard to get from the lakeside to over here, but there are definitely more options. Over the past 3 years, I've seen improvements in that.
Is there any association between low literacy and age group? In other words, are younger people more literate, or in other words, is there progress being made in that area, or do we have a way to know that?
Well, I don't think we looked at that specifically with this, although I will say that the Sierra Community House residents were younger overall. But I'm not sure if we might be able to look through and see if we can filter out by age if we saw that the literacy was higher in those that were older that were surveyed versus younger.
And your surveys are people your age 18 and over. Do I understand?
All over 18, yeah. But as a population, our random survey had more people over 55 completing the survey, whereas the Sierra Community House target survey, it was younger overall.
Oh, interesting. Meaning under 55?
Mm-hmm. For the majority, yeah.
Yeah, I guess what really sticks out to me as a barrier that I hadn't appreciated was literacy, that you can't give somebody a brochure if they can't read.
Mm-hmm.
They need an oral.
Yeah.
I want to elaborate on a couple of these, if that's okay, Maria.
Yeah.
So just so you guys know what the question was for what we're calling low literacy was, how often do you have someone help you read materials you receive from your doctor or hospital? So it was always or often, I think is where we broke it off as what. So, I mean, they might read, they could probably read a little bit, but maybe they just don't, the comprehension's not there. So they're having somebody help them understand it fully.
That question, though, is speaking more to health literacy, though, than to literacy in general.
Correct.
Yeah, okay.
And we would probably like to put a low health literacy would be nice. So our consultant's like, no, these have to be short. And I do want to expand on the language barrier because that's not misleading, but it's just bigger than that. It's have any language, cultural barriers, or your immigration status kept you from seeking medical care in the past year. So it's also bigger than just not speaking the language. It's their other concerns too.
The interesting thing is that that's 25%, so that's about, 1 out of 4. But actually, I might have thought it would be bigger than that. And the interesting thing is that when you look at, general adults, and there's 80% white population, so those people as adults speak English and don't have language barriers. And so it looks to me like there's a Hispanic, I'm assuming it's a Hispanic population that fits into the language barrier, low literacy categories. Do you think there's an association there?
Yes.
Yes. I think most of the people that we for the targeted survey were Hispanic. Not all, but most.
Want to move on, Maria?
Yeah.
Okay, so the last one is on health conditions and behavior. And this was also an interesting slide because we saw that the low-income respondents reported more positive behaviors in some of the areas. So they were less likely to binge drink, less likely to have depressive symptoms, less likely to experience some trauma, or abstain from their usual activities due to poor physical or mental health. But they tended to be more likely to be overweight or obese.
We'd be remiss if we didn't mention the impact of COVID-19 on some of our indicators, but I don't think this will surprise anybody. We measured economic hardships, which is, again, a series of questions. I think there's 8 or so that go into that one, but you can see we increased dramatically for our randomized population compared to 2017, up to 39%. Ever insured means that anytime during the last 12 months they had lost insurance, and that stayed relatively the same. You can see meals at home increased, which was good, but unable to afford care increased as well. And then, again, I think we all know this, that our low-income residents were more significantly impacted by the COVID-19 pandemic than our randomized and our overall population. So our low-income residents are more likely to experience economic hardship. Meals at home was about the same, which is good. I'll come back to this one. They, at the time of the survey, were more likely to be uninsured. That's total uninsured. And they were, had greater barriers to accessing of what affordable care. We added this one on after we'd actually created these because I want to point out that our low income, and as we just talked about, most likely more Hispanics in that respondent population, were more likely to experience severe stress due to a lost loved one in the past 12 months. And that brings us to our next steps. We're almost done.
Yes. So what we do now is we start to get this information out to the community and invite our partners and residents to learn about the information from the needs assessment. And through that process, we're going to be starting to identify priorities and areas for improvement and strategies around that. And we want to align our community health improvement plan with the Tahoe Forest Health System strategic plan. So that's great that this is aligning up together so that we can put things in place that will benefit both. And when we prioritize our action, what we have in the past done this is we based it on the magnitude. Like for the interventions we choose, how many people can we affect? So we're trying to pick things where we can affect the broadest number of people. By impact, how does the issue impact or exacerbate other health or quality of life issues? Will it impact in more than one way? Feasibility, can we make a difference with the amount of resources we have available? And then we also take into account feedback from all our community partners on the needs that they are seeing in their areas as well. And then we'll develop SMART objectives related to those 5 key focus areas that we've been presenting on. And that concludes our report. Are there any other additional questions that we can answer?
Questions or comments from our board?
I have a question about, is there a geographical concentration of low-income people in particular areas that are identifiable?
Yes, there are certain, we can go by different zip code areas, and we can look at that and we can target low-income populations. We know there's specific housing areas that tend to be more low-income, and we can target interventions that way as well.
So my thought is, if we could identify a sufficiently large and geographically dense area, we might be able to run a mobile clinic out there periodically or something like that that would be Spanish speaking and come to their neighborhood, so it solves transportation problems. And if we have somebody Spanish speaking who can explain the healthcare issues to them, we get past the barrier of people who can't read the literature that might otherwise be accessible. Anyway, that was just a thought that occurred to me based on the data that you presented.
I think, Director Barnett, that has been talked about. Harry has talked about, not just for the Spanish speaking, but for people who aren't able to access easily because of transportation reasons, that we can take out at some point in the plan to take out a mobile van out to help out with some of that health assessment and health care. Any other comments or questions in regards to this health assessment review? Mary, if you unmute yourself.
Yeah, I unmuted myself. I can't thank you guys enough. This is probably one of, I think, the most profound reports that we receive. And I just wish we could get it more frequently. I think it's, I don't think there's really any surprises in it necessarily. I think it quantifies a problem that we've known that we have. But it puts us in front of it. It puts it in front of us in a way that we commands our attention. And I just think it's so very important. I'd like to kind of go back to your next steps slide. You don't have to really do it, but are you separating the next steps as they relate to your targeted audience, or are these just universal next steps? Do you have anything specific to the targeted audience?
Oh, no, that would come up in terms of the overall plan. Like, you mean specific interventions targeted to low income population. Right. Yes, that would be part of our strategic plan, but this is like overall the approach we would take to come up with that community health improvement plan.
Right. And how often do you think we could get updates on this?
Well, we'd be very happy to come and present more often. I got to see you 2 months in a row, which is not usual for us.
Right.
But we present a lot of information at once. And when we're putting this together, Lizzie and I were also saying that it would be nice to be able to just take a bite-sized piece and present that and maybe do a deeper dive into it.
That would be great.
Yeah, and Maria, like those areas that you have talked about in terms of disparities in chronic disease and just taking those and talking about one of those and giving us, what is happening in that particular area. I know that when it might have been in another committee that we had behavioral health and there was an explanation of by somebody in the MSC that helped coordinate some of the depression screening and some of the other behavioral health screenings and what that was impacting on the client.
Yeah,
Mary?
Yeah, excuse me. I was just going to say it's also very gratifying, Maria and Lizzie, to be able to see that we have impacted the health of the community. You know, when you go back to your prescription opioid use and what have you. So, I mean, I think there's, you know, positive messages as well as challenges.
Yeah, I want to build on what Mary just said by saying that in the behavioral health area, there's some stunning improvement brought about by a series of programs that were implemented, you know, by your department. I would kind of like to see like a quarterly review of each of the 4 kind of targeted areas that you have. I mean, I guess I just broke them down quarterly because you had, seems like 4 targeted areas. And that gets us continually thinking about it as we're looking at all of the other programs and all of the other planning that we're doing. But I think, you know, at our retreat, the board was quite interested in trying to understand the community's health needs and how to gain traction with improving community health. And I think you're right on the forefront of the cutting edge of that. And a lot of this is original research on your part, which, you know, I think is advancing the community health significantly. And so I want to compliment you on what you're doing.
What we could do is take it back to the governance committee, or we can talk about it as a board and how we would like to have further information on the community health assessment and the progress being made on the programs that Maria and Izzy have been talking about, and then giving them just a focus of coming and speaking to us and not giving us the full picture, because we kind of get lost in the information, and would like to have more depth in one area of what's happening with the progress. So thank you so much, Maria. Are there any other comments from our board, or if not, the audience?
I just want to comment to Maria and Lizzie, because Louie and I had an opportunity to really sit and review the information. And what I have found is I'm excited the response by the board, because they do a lot of community health. Mm-hmm. And I don't think that everybody understands. And to be honest, this is just part of what they do. So I'm really excited that you are engaged, and I'm excited that Maria and Lizzie have been able to share, and I think they have more to share. So there's just a lot of different programs out there, and thank you, Maria and Lizzie, for you know, making it so it's understandable, and our board understands some of the community health work that's being done.
Absolutely, I share in that. Thank you. And as some new eyes on this, it's just really exciting to see the work that they're doing, and there's a ton of innovation there. So I applaud them on that as well. Look forward to continuing to work with them on this.
Yeah, I wanted to jump.
Okay, go ahead, Doctor. Go ahead.
I just wanted to jump in on the language barrier that Bob brought up. So I think one of the reasons why it's low is we have quite a few physicians and APPs that speak Spanish. During COVID, Maria and Lizzie put an amazing group together where we had physician leaders and a physician assistant who did a complete conference in Spanish all about the vaccine to try to promote the vaccine. They went out to our schools and promoted through the school district to get our Spanish-speaking community members at that, and it was recorded and was able to be watched at a later time. So by doing those things, I think is why that number is lower, and I just want to really give kudos to that team for that. Thank you.
Right. And thank you again, Maria and Izzy, for your report.
Thank you so much.
We'll move on to, we didn't have anything pulled from our calendar. Any board committee reports?
Two, so I'll keep them brief. One, the Hospital Foundation had a meeting earlier this month. Let's see, there's discussions around events to thank donors and generate new donors. Nothing really reportable there. I think the highlight of the meeting, though, was the report out of $936,309 raised to date, which the yearly goal or yearly target was $1 million. So just about to hit that, with 5 months to go in the year. And that number doesn't include a number of large donations that are known but just haven't been closed yet. So well above target on donations received. So far a great year there. And then the other piece that was really cool, the Velis robotic assisted knee replacement has arrived. So that was funded either in part or I think in whole by the foundation. So great to have that piece of equipment. Great asset for the health system. The other was a quality committee met. We had updates on both the PFAC and the Beta Heart program. We reviewed the quality assessment and process improvement plan, which was included today in the consent calendar and approved. Actually had a great presentation on access. This was one of the 4 areas. So every quarter we get a report on an area that the quality team is focusing on for improvement. And this one was on access, and a lot of great work being done there, obviously recognizing it's still a key challenge and a spotlight for the organization, but just highlighting one of the examples is a bus that's been, bus service that's been implemented for the cancer program to shuttle folks between our health system and South Lake, if I remember correctly, to provide access to a broader service area. And then the final piece was on a board quality education. It was a report on the future of rural health. And they spotlighted in that report a number of things that rural health systems can or should be focusing on. And what was fantastic is that there are a number of those are right within our sites and things we're working on. To all spotlight our strategic partnerships. We've talked about a few of those that we have in play. And then rural philanthropy, which I just talked about, really, really strong foundation supporting the work of the hospital. So great work being done there as well. I was in transit during that call. Alice, I don't know if you have anything to add. I got delayed by traffic, so I was in the car while that meeting happened.
But you listened to the committee report or the committee discussions very well because you covered it. You did a good job. Thank you.
Brief committee. I met with Ted Owens, and we worked on the language that is part of the rules of civility for public meetings. And so I think that will be coming back to the board for review and approval. But I think it's pretty readable, and I think we can attach it to agenda items so that when we meet out in the public again, those rules will be quite clear.
It's the order and decorum document that she's referring to.
Right.
Any other committee reports? Then we'll go to 14, our closing remarks. And I just want to make the remark that the board did have a retreat and that we've developed 4 goals that we want to work on this year to enhance our skills and our knowledge. And they revolve around education, committee function and structure, role and advocacy. And there was one more, and I unfortunately didn't write down the words after it. But we will be working on that in the governance committee, and we'll be bringing back that to the board to make sure that we have the goals correct and the strategies to go with them. Okay. If there's no further comments, then our next meeting is on March the 24th, and we'll see you then. Otherwise, this meeting is adjourned. Thank you so much for your attention and your participation.
Thank you, everyone.
Everybody.
Thank you. Good night.
Good night.